Hey everybody, and welcome to Argon Medical's ACEs program, state-of-the-art IVC filters and complex retrievals. My name is Catherine Berg, and I will be serving as one of the panelists, or the moderator for today's webinar. Today we are joined by two respected interventional radiologists. Our first presenter is Dr. Amin, who is on staff at Advocate Christ and also serves as an assistant professor at the University of Illinois, Chicago. He'll be presenting on IVC filters and retrieval kits. Our second presenter is Dr. Resnick, who is the Assistant Division Director and Clinical Site Director at Emory St. Joseph and Emory School of Medicine. He will be presenting on complex retrievals and going over several different cases. Following each presentation, there's going to be a 10 to 15 minute Q&A session. We ask that you put all of your questions in the Q&A section located at the bottom of your screen. At the conclusion, I will read the questions to our panelists and get their feedback and answers. And with that, let's go ahead and get started with Dr. Amin.
All right, thank you, Catherine. All right, let me get the screen share going, and then we will be off and running. Let me know when we have it going.
Yeah, you're good.
Are we good? We're at full screen, right? Okay.
Yes, we are.
Awesome. And Neil, feel free to chime in if you have any fun comments. But yeah, my name is Ketan Amin, vascular interventional radiology over at Advocate Christ Hospital. It's a suburb of Chicago in Oak Lawn, Illinois. It's a level 1 trauma center, big hospital, about 800 beds. So let's see here if I can advance the slide. Yeah, so disclosures are my disclosures. Obviously, I'm a paid consultant for Argon Medical. There's their mission and values. I just want to thank everyone at Argon who kind of made this happen, and all the other webinars that have been out there happen. They've been great about dedicating their time and energy to education via these webinars. It's a great way to learn about all their products, great way to kind of use it to improve the health of our patients and, benefit the lives of the patients we come in contact with. So yeah, thank you again, Catherine, and everyone over at Argon. So a little bit about me and my background. I've been, born and raised in the Midwest, went to medical school at Southern Illinois University in Springfield, Illinois. From there, went to residency over at Advocate Illinois Masonic in Chicago, and then my interventional radiology fellowship at William Beaumont, Royal Oak. And since fellowship, I've been mainly in the Illinois area. And yeah, so, as you can see my gear down there below, feel free to comment on that. But, we'll get started, and here's a general outline of what we're going to be going through. Filter indications we'll start off with. From there, we'll go to potential complications when placing these filters. Then I'll kind of hone in on the option elite, the design, and the placement. And then we'll kind of touch upon retrieval, filter retrieval, the kit in particular, and just the basics of it. Dr. Resnick will really touch upon the fun stuff of getting those complex filters out when they look all funny and placed in weird places. So in terms of filter indications, we'll start with the classic indications. So the classic indications, the ones we get consulted for the most, when you have a DVT or a PE, when there's the contraindication for anticoagulation. So those contraindications, include, not limited to, though, GI bleed, recent surgery, and hemorrhagic stroke. Other indications include failure of anticoagulation. So let's say you get the DVT or a PE despite being on your warfarin, Lovenox, heparin, or you get a progression of DVT. Let's say you have your femoral DVT, then you start on heparin, and then it progresses either down the leg or, propagates up. And that's another classic indication for placement of an IVC filter. So the various societies that are out there, these classic indications, they all kind of agree. There's basically a general consensus on all those. There are a little bit of variation when it comes to the expanded and the prophylactic indications, given lack of data, but overall they all kind of mention very similar indications for all this. So this table is from the SIR, the Society of Interventional Radiology, for those who don't know. And that's since we're both interventional radiologists, we kind of really kind of use this table a lot to know when filters are indicated. So we talked about the classic indications here. Then going into the expanded indications, so you got your iliocable or large free-floating proximal DVT, the so-called widowmaker. There's definitely can benefit from IVC filter placement in those patients. And then another one, you could read the chart here to know all the kind of the details. One thing we use a lot, and I'm pretty sure Neil is the same way, whenever we have iliocable DVTs or even PE for that matter, if we're going to go and intervene, a lot of times we'll go up there and place a filter, especially if they have a patient prone, you have popliteal access. Real nice having that filter kit that Argon has to really place a filter via the popliteal approach prior to initiating your thrombolytic therapy or doing your mechanical thrombolysis. If you're doing aspiration, plenty of things out there to use when you're treating iliocable DVTs. But a lot of times people go in there and place filter prior to that. In addition to the kind of the expanded indications, we have the indications when the patients do not have venous thromboembolism. Those are your trauma patients. So our Advocate Christ, which is a level 1, we'll see that a lot where patients come in with very complex fractures, pelvic bone fractures, femoral fractures. And we'll be asked to place filters in these patients, because they're going to be immobilized for a long period of time. So closed head injuries are also on that list. So many of these extended indications are attributed to the wide availability of retrievable filters. They've lowered the threshold for filter placement, mainly because of the general ease at which we can retrieve. If it's 3 to 6 months, usually these filters can be retrieved easily. And, there's definitely the percentage of ones that are not. But in most cases, if they've been placed within that 6-month time period, we can go in there and remove it without much difficulty. And, we've placed and removed a lot of these filters in trauma patients, and majority of the time it works out pretty well. It's just good to know though, like as physicians, and Neil will kind of back this up as well. If you're a physician placing filters, you should be a physician retrieving them as well, or at least going and following up with these patients and following these filters. The worst thing that we see, and when we see the 30-year-old, the 40-year-old patient that has a filter and that it's been in for 10 years and no one's following up, and it's just a recipe for disaster. And we'll show you pictures, of things that can happen when filters have been in for so long. But it's a good rule of thumb. Hopefully, if you're placing filters, you have a good way of following up. And definitely recently, the filter out movement has taken effect, and I'm feeling a lot more filters are being removed than they were about 10 to 20 years ago. So we'll touch on the prophylactic indications I talked about a little bit in the trauma patients. So, retrospective case series have shown that, placement of prophylactic IVC filters in trauma patients may reduce, symptomatic or fatal PEs. There's no randomized control, trials about this. But despite that, a lot of filters are being placed because of this. And, I've read studies, almost half filters being placed for prophylactic indications. Even more important than to follow up on these patients and make sure that these are getting taken out. So if you guys have obviously any questions about indications, these guidelines are available online very easily. The ACR, the SIR, very easy to look up all these indications. Same with the American College of Chest Physicians. They have a very detailed chart about filter placement and indications. The last thing you want to do is place a filter when it's not indicated, right? Because there's, they aren't without complications. Anytime you're going in, doing a procedure, placing what is essentially a foreign body in a patient, you run the risk of something happening. So we'll go through all these, but filter fracture is when part of the filter breaks off, embolizes somewhere. And Neil will show you some cool cases about that. Filter penetration is when part of the leg or the leg extends outside the lumen of the IVC, and I'm sure plenty of people have seen that. Most of the times it's asymptomatic, but and then you have filter migration. And that's when the entire filter is somewhere else where it's not supposed to be. If IVC occlusion is what we see kind of a lot and we're asked to treat, and IVC tilt, that can be problematic as well. I won't get much into non-target placement because that's really kind of has to do with operator error, but just know that that can happen. Non-target placement definitely happens all the time, and you may be asked to retrieve a filter that's in a weird place. So first we'll talk about filter fracture. It occurs when there's structural failure of the filter leading to fragmentation, potential embolization of the fragment. And you can see from some of these pictures I've posted here, the pulmonary artery is a very common place for a leg to get embolized to. Usually a late complication, seen after a filter has been in about a year. The overall incidence from studies that we've seen about 1 to 2%. And these can embolize to the lung, the heart, even potentially the renal veins as well. So filter perforation is defined as when the filter component extends beyond about 3 millimeters outside the IVC. So here's a bunch of pictures. If you're a radiologist and you're reading CTs, you'll come across these filters that probably been in for a very long time, and they're kind of touching the aorta, or maybe even going in the aorta, or touching the spine, or even the ureter here. Can occur immediately. What I've seen it's usually these filters have been in for quite some time. The incidence can vary by filter type, obviously, but published reports, right around maybe 20%. And usually they're asymptomatic, but if they're pressing on something that has nerve endings or pressing on the duodenum, patients are going to feel that, and you might see them in your clinic or get consulted on them. Filter migration is pretty rare with modern filters these days, with the exception of the Bard G2 that had a little bit higher rate of migration. Typically these days, if it's going to migrate a little bit, that means the IVC was pretty big, and so it was over that 30 millimeter or so capacity. So make sure, we all just have to make sure, do a nice venogram, and we size the filter appropriately for the IVC. There's also reports that filters can be dislodged by placement of central venous catheters. So, if you're obviously, as IR guys, we place a lot of central venous catheters. If there's a filter in, just watch that watch where your wire is going. Watch where the catheter is going. If you're using a J wire, make sure your J wire doesn't latch onto the filter, because it definitely can happen and dislodge them a little bit. And so IVC occlusion cable thrombosis, we're asked a lot of times, just ask Neil to treat these and go in there and try to do DVT lysis on these. So it's one of the more common complications related to filter placement. Published rates, anywhere from 2 to 30%. And I know that's a pretty wide range. We've always, been taught, at least myself in residency, right around 10 to 20% is the kind of, quoted rate of which this happens. Obviously, it's going to depend on what filter is being put in. As you can see, I don't know if you guys, some of you may remember the Simon Nightingale filter that's in this picture here. I've seen this a lot, where you have one of these older filters and cause, entire thrombosis of the cava. Here we have either an optes or a trapeze here, but those tend to cause that, and I'm sure Neil can attest to that as well. So, and then lastly, we'll get into IVC tilt. Clinically significant tilt is really defined as a 15-degree angulation of the long axis of the vena cava, kind of like this. So it's very common cited cause for filter retrieval failure. So as we know, I'm sure many of you have been in the situation where it looks very easy to retrieve. It looks like it's in the middle of the cava, and then lo and behold, it's tilted to the back wall, and you have a tough time, and you have to start using all sorts of fancy tricks to get it off. So when the tilt is greater than 14 degrees, there's some reports out there saying their increase of PE is higher, which makes sense. And so here's just a kind of a quick rundown of the types of filters out there. I know Neil we'll go into types of filters as well, in terms of retrievable and non-retrievable. But some of these old ones, it's probably good to kind of get an idea of what they are. The Simon Nightingale, they have this kind of characteristic look. The Venatech LP, there's a Venatech LP out there, low profile. Then you get your Greenfields, your Bird Nests. And in terms of retrieval filters, you'll come across all all sorts of different ones. So, obviously there's the option where we're talking about. You got your Cook filters, Bard, and, quite a variety that are out there these days. To just kind of know what you're dealing with, and, try to be familiar with what's out there is what I would kind of recommend. So, we'll delve into the Option Elite specifically, since this is an Argon talk. So this is a magged up view of the Option Elite filter, and we'll go through the design here. We'll start at the apex. So it's a unique apex design. It's really designed for easy snare capture and retrieval. The open apex design kind of helps. It's nice that, most of the time when I've gotten my snare around this, I've been able to get this filter out. So it's kind of a nice feature. Another good feature, this is a single nitinol construction, enhanced integrity without any welded joint. So that's going to really decrease the rate of fracture when they design this. And then you get into the anchors, which are really, designed for stabilization, make sure, they're really designed to make sure that these things don't migrate. And then the legs here, the anchor extensions, are help to prevent perforation from from outside of the IVC. So they took in, the engineers really took in a lot of those things that can go wrong with IVC filter placement to try to decrease the risk of any of those things happening. I mean, they can still happen, obviously, but it's just nice to know that those things were thought of when the engineers had designed this filter. And it's one of the many reasons I do kind of like this filter a lot. When you open the packaging, this is what all is going to come in. You got your curved pusher. The curved pusher really is going to help you place this filter where the tip is in the center of the IVC, especially when you're going from a femoral approach. I like that the sheath is great. It's a 5 French, really low profile, design. It can be placed. I'll get to the next slide. We'll talk about where you can place it from. You have your dilator, and then the filter itself is loaded into a cartridge. So it's nice. You don't have to carry different kits on your shelf in your IR lab. You don't have to carry a jugular or a femoral. Really one kit. And depending on which way you go, you flip this around, and then you're ready to really rock and roll. The differences really that they sell are the length of the kit, which gets in, depending on where you want to place it. So great that you have many options for access site. My most common, maybe Neil's as well, probably jugular. But you can also go femoral, has that option. You just flip the filter cartridge around and you can place it femoral. And then, like I mentioned earlier, when you're doing a thrombolysis, you do mechanical thrombolysis, through a popliteal approach, you have a long DVT kind of going from here up to here, cross that clot, and you get up there and you just pop the filter, and then go to work trying to get the clot out. It has the 100 centimeter delivery system, and I've yet to place it in the antecubital, but I know it's possible. So maybe Neil's placed it there, but yeah, it's a good option to have if you're in the arm and you want to place a filter. So, and then there's the 2 ways to deliver this, which is also unique of the option filter. We'll get into that. So standard deployment, you kind of go at it however you normally go at filter placement. You get renal, or you get venous access. Do your venogram, identify the position of your renal veins. You advance the delivery sheath, you load the cartridge, jugular, femoral, whichever site you're going through the sheath hub. Then you use the supplied pusher, the curved pusher, and that will basically push the filter in place you get to the desired location, and it's a pin and pull mechanism where you unsheath and it pops out. So the curved pusher is nice. And, if you're ever in a lab or something with STIBs or any of these clinicals, they'll kind of give you a lowdown on how you want the pusher to be oriented, especially if you're going through a femoral approach. And it really kind of helps getting that apex lined up with the IVC and making sure there's no tilt. That's another great thing about this. And then I think this is probably unique of the option filter, because I don't really know any other filters that can be placed over the wire. Another nice little feature of this. Also, it's going to help. The whole point of this is to reduce filter tilts. so that you can increase the chance of filter retrieval. So how you do this, you get your venous access, do your venogram, identify your position, below the level of the renal veins. And what you do, you're going to remove the dilator over the wire. You'll advance that cartridge over the wire and hub it. Then you'll use your sheath dilator to push the filter through the sheath, and that'll kind of push it all the way up there. And once you're in the right spot, you're going to pin and pull, and you'll still have this wire up through the apex, and you'll pin and pull. This will pop out. You'll still have the wire through, and if everything looks good, which it should, then you just remove the wire, and that's it. So pretty straightforward in terms of over the wire and standard deployment. So, and then lastly, we'll get into the retrieval kits that they have there. They finally have retrieval kits. I've been begging them for years now to have this, because before, I don't know what you were using, Neil. I mean, my standard retrieval kit was the Cook retrieval kit. Anything that was kind of like straightforward. It was like the Tulip, Cook Tulip recovery system. So I think that was used by a majority of people out there before they had these come out. So I'll go through these. There's a single loop, there's the triple loop, kits that are out there. And we'll kind of mag up on the next slide, but they have a coil reinforced outer sheath, which is nice for stability. The sheath has the marker band, so you can see it, you know exactly where you are. I really like that there's a 15-degree bend on the snare catheter. If you have a little bit of tilt, you're going to be able to really control where your snare is going to go and try to engage that hook. You got the side holes on the dilator. You could do do a flush venogram through the dilator, which is nice, and obviously the multiple snare options. So when you open the kit, this is all what's going to come. This is you got your 11 French outer sheath, you have a 9 French inner sheath, your 8 French dilator, and then your snare catheter is about a 7 French, and comes with the single, like I mentioned, the single or the triple loop, and you get all the other stuff with it, like you got the Tui Borst on there, and then you have the stopcocks. Here's a magged up view of the single loop and the triple loop here. And as I mentioned before, this nice rigid sheath to help you really get stability for those filters that are really adherent to the IVC wall. And here's obviously the slight angle on that snare catheter will help for directionality. And obviously the radio opaque bands. And yes. So overall, the take-home points I really wanted people at home, as they're drinking their cocktail and having a nice little happy hour, be open, try new things, try new devices, new products. You never know what you're gonna like out there. There's a variety of filters, variety of, filter retrieval kits. I told you why I like the option, but really, it's up to you what you want to use. But I just stress the importance of being open. And then once you find something you're comfortable with, make sure that product very well. Another thing, in terms of filter placement, it's important to make sure the indications, make sure you're placing these filters in patients that need filters and not unnecessarily. And when you place filters, make sure you have a plan. Is this filter going to come out soon? If it's going to come out soon, have either your PA or have someone write it down on a calendar. There's many ways to do this, but make sure you keep a list and follow up with these patients with their primary when they're adequately anticoagulated, when we can get those filters out. And I think that's something really important. It's really come a long way in the last 20 years, and we're doing a great job as interventional radiologists about. Then know your complications. So know what can happen when you place these filters. Know how to fix it, or know when you can't fix it, where to send it, and who has the good experience in terms of retrieving complex filters. If you need to send them to Neil all the way down into Atlanta, go for it. That's he'll be happy to take care of your filter retrievals there for you. So yeah. And then other than that, we'll open it up for questions. Here are my references, and I'll throw it back over to Catherine here, and I'll.
Awesome. All right. Hey, thank you for that. So we have 4 questions. So I'll just start down the list. So what is the most common type of complication you see when placing filters?
I guess it depends. When you have your immediate complications versus your delayed complications, right? I think by far delayed complications really end up being cable thrombosis. And Neil, feel free to chime in if what you've seen. Cable thrombosis very common. In terms of delayed, and definitely perforation. A lot of times with perforation, it's usually subclinical. It's just something you maybe find on a CT scan. You read a CT abdomen, you'll see that this filter is kind of poking out where it shouldn't. And it's one of those things where this filter should have been followed up closely and taken out. And that's when you maybe put in a phone call to the primary physician, say, hey, patient has a filter in for a long time. Maybe we should get this out. And then, obviously filter your cable thrombosis, you see that, you really want to put in a call, be like, hey, this is something interventional radiology can really take care of, or whatever specialty you're in. If you're adept at thrombolytic therapy, it's something we see a lot. In terms of immediate placement, depending on what type of filter you're placing, sometimes they don't come, sometimes they'll be tilted a little bit. I don't know if you call that a complication. It's a little of annoyance when you see that. And especially if one of your partners is trying to go in and retrieve a filter that you placed and it's all tilted, you might get someone swearing at you down the road. But other than that, those are the ones I see a lot. Ed.
Yeah. Okay. Thank you. So the next question is, how does the Argon Retrieval Kit compare to the Cook Retrieval Kit?
They're very similar. I'll be honest. They're quite similar. I do like how rigid the sheath is and how the stability it provides. Like sometimes, when you latch on to the hook of a filter and you're trying to sheath, it's all about advancing your sheath over it. You don't want to pull, and Neil will talk about this too. I mean, it's not a pull. It's a push on your sheath in order to collapse the legs. And it's important that you have a very rigid sheath in order to kind of get that fibrous tissue to kind of come off the legs of the filter. So that's really awesome. That's a good feature of the Retrieval Kit. And like I mentioned earlier, that little bend on the snare catheter, every little bit helps, in terms of if you have even a slight tilt, it just makes your job much easier if you can, control where that snare is going.
Excellent. Next one, where do the majority of your filter referrals come from? Are they coming from trauma or hospitalists?
So yeah, at least here at Advocate Christ, almost all services. And it's usually, a lot of times you'll get it from hematology, oncology. Patient, presents with DVT, can't anticoagulate them. Even the primary service, it really comes from all over the many different specialties, not just, but additionally trauma and hemonc are kind of in particular ones we see a lot. But any specialty that's dealing with DVT and venous cases, we'll see that. Any family practice, internal medicine too.
Interesting. Very cool. And so we have another one here. We got two more. So where do you place the filter apex? Mid-renal vein, below it?
I try to target kind of mid to below renal vein. There's the theory that if you can get the apex kind of within the middle of the renal vein, whatever clot gets trapped into the cone potentially gets dissolved by the inflow from the kidneys. So if you're going to go as precise as you can, sure, that would probably be, I would say, mid to lower aspect of the renal vein. But, anywhere you're safe kind of there or slightly below.
Okay. And last one. So this one's about patients and how do you get them back in? So what percentage of your filters are retrieved and how do you get your patients to come back, or what infrastructure do you have to get them to come back?
So it's good to have, at the last two places I've had, we have really good mid-levels who follow up on it. And if you have a practice with mid-levels, it's great. They, keep a list. They keep a list. That's typically what they do, and they follow up kind of on a pretty consistent basis. And usually, if you have dedicated follow up and you're really following them closely, there's no reason that, you know, over 75% of these filters can be coming out.
Yeah.
You
Do they
know,
follow up with the referring physician or the patient themselves?
usually it's through the referring physicians, but we'll also get a hold of the patient as well. You know, we want them to be able to know if they're adequately anticoagulated, and that's usually kind of, you know, through the patient's primary physician or their hem-onc doctor. And if they're tolerating, you know, their Lovenox or whatever it is they're taking, and they don't need it, then we'll schedule them.
Okay. Very cool. Let's just do a check. Oh, we got a couple more here.
Sure.
So I found the dilator to be quite tight when using the over-the-wire technique. Any particular wire you like to use for that? I have used an Amplatz, and it is sometimes difficult to push over the wire.
Yeah, I'll be honest with you, I've not placed it over the wire that many times, only a few times. But you're right. I've read maybe a stiff glide wire might be good for that if you can get it nice and, you know, it's not very sticky. Yeah, I would have tried, you know, I think the few times I've done it where it was with the Amplatz wire. I know other people will use a J wire. You just have to be careful when you're removing it to make sure that the J doesn't get, you know, really hooked on to the top of the filter. I don't know, Neil, have you ever placed these over the wire and you use a particular wire?
Yeah, can you hear me?
Yep.
Okay, cool. Yes, and I don't do it that often either. Actually, I don't find it's always so necessary.
Right.
And sometimes, personally, you know, I find it that I want to make sure I use a softer wire, kind of like you mentioned. I'll just use even a Benson.
Yeah.
And a lot of the reason for that is because, one, yes, it can get kind of stuck there. I find it's a little stiffer, but like an Amplatz. But the other thing is that if it straightens out the IVC too much, and then you drop your filter, and then there's recoil of the IVC, it actually then the hook could be, you know, could be tilted, could be up against the wall. So I do like, if I'm going to place it over a wire, I will place it over a softer wire, like
Softer wire.
Nice,
perfect.
I also worry about the J wire too, for the same reason you mentioned.
Yeah.
Nice. And then you got a shout out from Matt Sharp.
All right, Sharpie.
He likes your. He wants to know if you like bourbon on the regular with your rep.
Of course. I hope he likes my A glass, you know, for Amin. There you go. It's handed down many generations of Amins. I've had these glasses. I was happy that I stole these cups from my sister.
Very cool. So that was our last question. And with that, we will hand it over to you, Dr. Resnick, to talk about complex retrievals.
Okay, cool. Thank you. Actually, before I start in with my talk, I just kind of want a couple comments. I tried to comment during the talk, and I think it was muted, but you know, Ketan asked some really good questions. I sometimes will also place these from the upper arm veins, especially if I know that they're asking for like a pick also, because I find with a 100-centimeter delivery kit, it's kind of nice to deliver it from, say, one of the upper arm veins, and then just on the way out, just drop in a pick. And I find that to be
nice. Yeah, I've yet to do that, but yeah, that's
yeah, it's a nice little trick.
It's a nice little trick there. Yeah, cool.
And I want, and that way you don't have to hold pressure either. It's kind of just drop a pick.
Yeah, that's true. There you go.
Single time. And I wanted to ask you, Ketan, too, how much do you care about placement? Because, like, you know, below the renal veins, you do care where you go, transrenal. I will tell you that I've, you know, I try to be so precise sometimes, and we have trainees, and we kind of show them, oh, you know, we're teaching them, make sure you do it right here with the tip, right, transrenal and all that. And meanwhile, I see the vascular surgeons, and literally they couldn't give a damn, right? They'll just live, as long as it's above the common iliac vein confluence, that is cool for them, you know. What do you do in your practice?
Well, I'm not so particular to have it exact, but at the same time, I'm not just willy-nilly going to throw it in anywhere. You know, I can say maybe I'm kind of in between. I want it close, you know, up there with the apex, at least kind of at that level of the renal veins. Mm-hmm. But obviously, I'm not going to retrieve it and you know, position it if it's not exactly where I want it, you know.
Yeah.
But it's great. You work with residents, it's better to have them be, more particular than not.
Right. Right. Very true. So I want to first say thank you to Argon for putting this on. This is really awesome. And thank you to Ketan for setting up my talk so well. You did kind of the hard part, in my opinion, and I get to show all the fun stuff.
All right.
As a myth. And I also did want to thank my former partner, Mitch Ermentrout, who provided me many of the cases I'm going to show, and my current partner, Megan Lilly, who also shared some of the cool cases that I'll be showing. I have a couple disclosures. I'm a speaker for Argon and a speaker consultant as well for Terumo. I will give you a little background about complex filter retrieval. We'll talk about the indications for it, the preparation that I do, techniques I use, and some of the complications that can occur. As you know, there are a number of retrievable IVC filters on the market, not just the option. Although I will say that I'm very proud to say that I think I was one of the first users of option out there. When I was a resident up in Maine Medical Center, we were on the original study, and I got to play with it many years ago, and that was pretty cool. We knew right away that it was a great product. So Retrieval IVC Filter Complications, the MAUD database is a really useful index, and it's identified an increasing number of complications associated with retrievable filters, and you can see them here. We have an increased risk of DVT, IVC thrombosis, IVC penetration, vena cava filter fracture, as well as migration and embolization, as Ketan had mentioned. And in 2010, and it was updated in 2014, the FDA issued a safety alert emphasizing the need to retrieve the filters when they're no longer indicated. And that's something we all try to do, but as Ketan also mentioned, it's, the success with retrieving them is really highly variable amongst us. And myself very much included in that. I've gotten better with that over the years. And these filters are most beneficial when removed within 90 days. So around 65,000 IVC filters are placed annually in the US. That's a staggering number, especially when Ketan mentioned that we all know that they're helpful, but the data is sometimes, kind of either way on it, but we all know that if it's our family member, we're gonna say if it's indicated, we're gonna place it. And around 35% are eventually retrieved. However, there are some studies that show as low as 8% are retrieved. And most retrievals are straightforward with a standard kit, just as Ketan had very well described. Retrieval remains safe and feasible even with clot burden. So I know that I always do a run before I try to take it out, and I tell my now residents, these two fellows, my residents, that you really want to look for that, and you want to try to make sure there's no clot. But actually, retrieval is safe even if there's a small amount of clot, less than 25%. And we need to do advanced retrieval techniques if the hook or the legs are embedded beyond the cable wall, and we'll talk more about that as we go. Indications for retrieval, really, if you break it down, is it should come out, the filter should come out when it's no longer indicated. That's when the risk of PE is now low, and so the patient may be tolerating anticoagulation or the clinical status has changed. Of course, you want them to be living longer than 6 months, or it may not even be worthwhile to undergo another procedure. You want to do it when the filter can be removed safely. And you want to make sure there's not going to be any anticipation of future filter need. For example, major upcoming surgery like orthopedic surgery. We know that prolonged filter dwell time is associated with complications, and those include device fracture, migration, organ penetration by device components, elevated risk of DVT. And longer dwell times correlate with the embedment of the filter apex and retrieval difficulty and failure. And the studies have shown this, that the mean study of Resursi of 628 retrievals, they have a registry and they looked at it. The mean successful retrieval was 85 days. Unsuccessful retrieval was 145 days. So obviously as time goes on, you're less successful retrieving these. And in another study of 259 patients, there was increase in challenging cases over 50 days, and failures, increased number of failures over 90 days. So SIR clinical practice guidelines were recently updated last year, and as Ketan mentioned, they do recommend the use of structured follow-up to increase retrieval rates and detect complications. Those include multidisciplinary programs, enhanced patient education and provider communication, automated reminder systems like automatic calls and mailings to the patients to remind them that it's time to check in with their IR to get the filter removed, and dedicated IVC filter clinics. The most important thing is to plan retrieval at the time of placement and follow up until the filter is out. So what are the barriers to retrieval? Poor clinical follow-up, and we know these patients that just get lost to follow-up and never show up again. Technical challenges related to filter removal, and those include what we'll go over, including tilt, embedded hook and apex, embedded struts, component perforation, component fracture and/or embolization, and of course, as we mentioned already, the dwell time. So what is the window for retrieval? We know that there was a study by Desai et al. Looked at 648 retrieval procedures with 97% overall success, and there was 98% success that performed less than 6 months, slightly lower, 94% success that performed over 6 months. So again, we're starting to get an idea of how soon you want to take these out. And for those requiring adjunctive techniques, meaning our complex filter retrievals, it was 11% were needed of these techniques if filter retrieval was performed within 6 months, and it went all the way up to 67% if performed over 6 months. Another study, 762 procedures, and it looked at, again, IVC filter retrieval when using standard techniques and adjunctive techniques. And what you see is that the good news is with all this, that standard techniques, 82% were removed successfully, and with these adjunctive techniques that we'll go over soon, we had 98% success. So the good news is if you use these techniques, you are almost certain to be able to remove the filters. And there's no significant difference in adverse events between the groups that use standard techniques and adjunctive techniques in this study. Good news. So we talked about the dwell time and when does the risk of standard retrieval technique failure increase. Here's a little chart showing you the inflection points, and really it's around 7 months. So that's sort of a good time to think about. 6, 7 months, you want to make sure you can get the filter out as soon as you can. You know, we tend to talk to our patients and try to bring them back. We check in with them at 3 months and see if it's time that we can take the filter out. That's what we do at Emory for the most part. And as far as when we look, how do we prepare these patients for retrieval? What do we need to do? The SIR guidelines actually do give us some information on this. And so they say that they are not, that you should really continue the therapeutic anticoagulation, which is interesting. It's not associated with any increased risk of complications. And they argue against the pre-procedure imaging and lab studies, except in certain cases. And those certain cases include when you have prolonged filter dwell time beyond several months, or if there's known substantial filter tilt or tip embedment, in which case I would say definitely get a CT. So if you have any concern, if you're not sure what the case may be with a filter, it's been in a while, I would recommend getting a CT just to see what you're starting with. There's very little loss with that in most cases, and sometimes you really can be surprised what you see. And if patients have symptoms of possible filter-related complications, such as lower extremity swelling, DVT, abdominal pain, or GI bleeding, you may want to dig a little deeper, get a CT, maybe a lower extremity Doppler ultrasound to see if they have, DVT. And if there's a high likelihood of advanced retrieval techniques being required, then I would definitely get labs. So I would get platelets, coags, and renal studies for sure. And so we're going to talk about these advanced retrieval techniques in the setting of filter tilt, in which case you can consider realignment. We'll talk about that. Embedded hook. We're going to talk about these techniques, which are pretty cool: balloon displacement, loop snare, fiber cap disruption, Hangman technique, and endobronchial forceps. If you have embedded legs, using the laser sheath, If you have adjacent arterial injury, again, you might have found this out with the pre-procedure CT, then you want to get concomitant arterial access and consider embolization. So let's talk about filter tilt. The first thing I'll mention is that if you use a curved sheath through your outer sheath, then that can actually give you some steerability of your snare. So typically the sheath that delivers the snare is straight, but again, if you use a curved sheath through the outer sheath, it can help you to, especially the filter is tilted, but its hook is not embedded in the wall. It can be useful to put to help steer that snare around the hook. And I'll just show that again here. So again, curved inner sheath. And studies do bear this out, that it can be helpful. Now, one thing I do want to comment on is that often we'll look at these filters and they look great. You know, they look like right in the middle of the IVC. In fact, we'll do a run beforehand, and it looks dead smack in the middle of the vena cava. And what we often don't do, at least I don't do, I don't know if Ketan, if you do this, but if you then go in a lateral projection, you might see that actually there's some AP tilt either against the anterior or posterior cava wall, and that can be very difficult to assess from just a frontal view, which most of us use. Ketan, do you regularly do that? Do you do a?
Yeah, not regularly, but you're right. If I'm sitting there struggling for a little bit, you know, I'll take a look and at least give myself some oblique views and figure out what's going on. But you're right, that those can be quite deceiving and frustrating when they look so good and you can't get the tip.
Absolutely, absolutely. And so that takes us to our next point, that sometimes, like you can see here, this is a filter in which there's posterior tilts of the apex of this filter, and the hook is and the apex are embedded in the posterior wall. So that may be one type case that Ketan's alluding to, where it looks so good and you're going out with your snare and man, you just can't get that. So this would be good to know ahead of time, of course. So you know you're going to do advanced techniques. This is one of those kind of cases, right, where it kind of looks pretty good, and then you sort of see that there's maybe like a filling defect over here, and you're like, oh, maybe it's hooked on the wall after all. And sure enough, you know, you did see that on the CT. You can see it right on the image next to us that it's actually up against the wall. So one technique you could use in a case like that is called balloon displacement, and we use it when the hook is embedded, and it's pretty neat. So what you can do is you can use a catheter just with a curved tip, an angled tip, and send a wire, as you can see here, around the apex of the filter. So between the filter and the vena cava wall. And what you can do is to try to displace it away from the wall. You can throw up a balloon and see if that's enough to just pry it, pry that hook, kind of pry that fibrin cap, if you will, off. And it works in many cases. I tend to use an 8 to 12 millimeter balloon when I do this. If that doesn't work, I'll often go to my next go-to here, which is the sling technique, and it's also called the loop snare technique. And you have a little diagram there that shows it. And essentially, you're going to take a reverse curve catheter, go down below the apex of the filter, and send up a glide wire. And through your outer sheath, you can send down a snare and then actually snare that wire through it. And it's nice. Then you have control over the filter. You send it through the struts. What I like to do, especially with the option filter, is that you can send it through the kind of top part of the filter, apex of the filter. Ketan had a nice picture of the filter, and unfortunately I don't have one here to show you. But if you send it through the top strut area, it's through the metal up there, it's going to give you more control over the filter. So I try to do that wherever possible. If you don't have an option filter you're working with, or you're taking out a different kind of filter, you want to get this at least, and even with option filters, quite frankly, you want to repeat and get at least 2 wires through 2 legs, 2 struts, and you're more likely to be successful. And then what you'll do is you'll get back tension on the wires, But as Ketan also mentioned, you're going to then take your sheath and you're just going to oversheath the filter itself. So you're not actually pulling back so much because if you do that, you can distort the filter. It makes it much harder to take out, but you're really just holding it there and trying to oversheath it if you can. So this leads us to our next technique, which is filter cap disruption. And sometimes when you do a run, you can actually see a filling defect right against the hook, the apex there, and that's actually a fiber cap. So if you see that now you'll recognize it. And there's actually a different technique, all that's related to what we just showed, but slightly different. You try to get your reverse stroke catheter positioned so that you can send out your wire between the cap and so like just right around the hook. So between, you know, kind of through the cap, in other words, between the apex and the wall. And you can see here, it's pretty cool. You're actually pulling on the cap itself. And you can see in this diagram exactly what's happening. So if you're able to do that, excellent, that's awesome. And then you could basically just try to snare the hook after that. And you can actually see in this picture here, it's a nice illustration of what that fiber cap can look like. This is often what I find I end up doing, even in the setting of embedded apex or sometimes the fiber cap, and that is I'll use multiple techniques. I'll end up sending those two wires down, like I mentioned, and get more control over it, the filter. And so like in this case, we actually had control. We had the two wires through there, and then had another glide wire around the fiber cap, and then just kind of pulled them all together. Another technique is called the Hangman Technique. Again, this is related to the Sling technique as well. It's just slightly different. So whereas on the left hand image, you'll see the Sling technique, again, that loop snare technique. On the right image here, you can see how it's slightly different. So instead of going through the legs, you're actually going around the neck of the filter, and that's why they call it the Hangman. And sometimes it really does look like you know, kind of that I guess grotesque you know, image. You can see here where the filter actually, it's like a person hanging or something hanging. It's quite terrible, but it's useful. It's a useful technique, and sometimes that alone is enough to just pull the filter off, so you don't have to do multiple wires. Just a couple examples I'm showing here. And again, in this case, you're oversheathing, just like Ketan said. It's not that you're trying to pull back. You're trying to distort the filter as little as possible, because if you distort it too much, you're going to have to resort to some heavier duty techniques, and those include endobronchial forceps. And while this is, you know, kind of sexy and kind of fun, it's definitely there's some risks to this. So what your goal with endobronchial forceps is to dissect the neointimal tissue from the hook that's embedded in the cable wall. So you're actually trying to itself grab off that neointimal tissue, that fibrin cap, and or you can just try to grab the neck again of the filter and just try to pry it off the wall. And what you want to do when you go in there, you want to be careful not to over distend the IVC. It's really uncomfortable for the patient, actually, when you do that. So in most of these cases, I still do under moderate sedation. Although if it gets really kind of fancy, and I think it's going to be really tough to do, I will do it under GA. But just note that if you're going to do it under moderate, that they're going to be feeling that when you open up that the alligator forceps there, and then there's the risk when you come down that you may be grabbing the wall itself rather than you know, the neointimal tissue or the neck, and you just want to be really careful about that, because you obviously don't want to cause a rupture, a laceration rupture. So ultimately, you hopefully will get one of these very nice Twitterable pictures that I found from AJ Gunn from UAB. Very nice image there. So thank you for that. This is a variation of the technique, and this is from my partner Megan Lilly. She did this while she was at Columbia. And this was first described by the cyanide guys. I was doing some of these cases when I was there as a fellow. And you basically go, it's a variation on just the interruptive forceps from the neck, from the jugular. You'll go down from the femoral vein, and you'll grab it there and invert it. Sometimes that actually ends up being a bit easier to do it that way. And here, a picture of the alligator forceps. I tend to use, for everyone out there who might be interested, doesn't currently have them, it's a model 4162, and that's really the alligator one's kind of right over here. Really like that one. So again, just showing you a few more examples here of removing filters this way. I tend to use 18 French sheath for this from the jugular, just an 1840 Cook sheath, for example. And if it's from the groin, I tend to use 20 French 28 centimeter Medtronic Centrant sheath, which is very it's braided, it's very strong, and because you're inverting that filter and you're really going to be mucking it up, so to speak, it's nice to have something that's going to tolerate that and not get damaged. So here's where we use multiple techniques, and this is not uncommon to have to use multiple techniques. You definitely want to have these different skills. You can see in this one case, you're using the sling technique, the loop snare technique, to kind of give a little more control and grab it. And then you've got another operator who's kind of helping out to just grab that hook. And I'm not often that skilled to be able to grab the hook like that. I'm usually more the type to grab the neck or really muck it up. This was, again, Mitch Ermentrout's case, and kudos to him. Sometimes when you have embedded struts, then you can see in this case that they might poke into different structures, perforate different structures, but more importantly, in most cases, because that's often asymptomatic, but it can be really difficult if they're perforating it can be difficult to remove the filters. It's often not, interestingly enough, even when you have the perforation. But sometimes you'll find that it is difficult no matter which filter you're using. And if that's the case, you may have to rely on more advanced techniques kind of focused on that. And what you will see, if you're going to inject contrast while you're trying to take the filter out, if it gets kind of stuck, you'll see, as you do in this picture, that the filter actually, the vena cava itself collapses down. And so you'll know at that point that that's really your problem, is that your struts, your legs are embedded, and you might have to resort to this technique, which is using the laser and Spectranetics. I think now it's Phillips. And this is a pretty cool device. It was initially used to remove embedded cardiac leads, and we've kind of co-opted it for our own use in this setting. And it's an 18 French sleeve. And let's go back to that for a second. It's an 18 French sleeve, and it goes through a 20 French sheath. It doesn't, just one thing to note about if you're going to use the laser, and it doesn't actually have on the back, sorry, over here, it doesn't have on the back of it a port. And so you can take just a standard sheath, and like a vascular sheath, 10 French, and just kind of stick it in there, again, totally off label. But if you don't want to bleed back, that's something you can do. So component perforation, we also get this too. It's typically asymptomatic, again, when those legs are poking through, and it does not decrease retrievability in most cases. And there's really no impact on the efficiency of the PE protection. In other words, it's still protecting from clot, and it correlates with dwell time. So the more time it's in, the longer it's in, you'll see more and more of the legs kind of pop out of the IVC. And most of the cases, as shown in this study of 9,000 patients, that there's 19%, almost 20%, did have perforation, but only 8% of those cases were symptomatic. So very small percentage of the patients who have that have any symptoms related. And I want to show also a case of component fracture here. And you can see, if you look on this image on the right, that after the filter is removed, that there's a leg there, so you're going to have to go in and get that. Here's another CT that shows something similar. If you missed it, it's very easy to miss. It's easy if you're scrolling yourself. You can see all the way here in the hepatic veins, there's a leg somehow got there. You have to go in and get those. In this case, it was retrieved with just a regular loop snare, but you also can go at these and get these with Alligator forceps. So talking about component fracture and embolization, we see that according to the MAUD database, up to 16% of users reported that, correlates with dwell time. And let's see, just gonna skip through some of the stuff for the sake of time. But another thing that Ketan actually spoke about, another consideration is if you have cable penetration of thrombosis, right? So this is something we see non-commonly. And by the way, you can see in this case, it's sort of a nice view of one of the legs poking here into the aorta. I don't know if you guys can appreciate that right there. Again, asymptomatic in most cases, but you'll see some crazy things. I've seen them poking into duodenum, I've seen them poking into the spine, and providers, referrers often get pretty concerned about that. Patients do too when they find out about it, especially if it's kind of poking somewhere strange, but in most cases you'll find it really doesn't make any clinical difference other than maybe a concern for it. Now, what does make a difference is if you run into this thrombosis, and Ketan showed some cases of this too, so I won't go into it in too much depth, but we often, in that case, if you have thrombosis kind of behind the filter, you want to thrombolyse, and then afterwards you can go at your filter and remove it. This is an interesting case that I just got as a case report. I found one of the studies, and it's a case of where you can see here that there's a leg that's poking out of the IVC, and it has caused injury to a branch of the SMA. So this was discovered on the pre-procedure CT, and a decision was made at the time to get concomitant arterial access, and then they very wisely so decided to embolize that branch of the SMA prior to retrieval of that filter for obvious reasons. They didn't want to cause a big bleed. So what do we see in terms of the complications? That even for the standard loop snare technique, there are possible complications, right? Any procedure has possible complications, but it's very small for the standard removal from 0 to 5%, different studies. Once you get to bronchial forceps, that does increase up to, the complications increases anywhere from 1% to 12% in the literature. And those complications will include leg fracture. Of course, you can use the same forceps to then go after the legs. Contrast extravasation, hemorrhage, and IVC, renal artery IVC fistula was described in one case too, actually two cases. And laser-assisted removal, you see actually a real small percentage of complications, maybe because the folks who are doing that are pretty sophisticated when they get that level. You can see Quo here, who's has probably the most experience in the world on this. It has 3% of complications in that study from 2013. And then the Sling technique, interestingly enough, has anywhere from 0% to 20% complications that include IVC dissection, contrast extravasation, and spread fracture. So advanced filter retrieval compared with simple removal, I will say that once you get to the advanced techniques, you will have anywhere from, you'll have 4 times and 13 times greater overall and major complications. So you will have more complications because, again, these are filters that are really impacted in the cava, so you'll have more complications getting them out if you have longer dwell times. And you also have greater fluoro time, so about 5.4% greater fluoro time and 3.6 times greater radiation exposure. So all the more reason why you try to get these out as soon as you can. And just on my final parting words here as part of the presentation, I would say make sure you get you do good pre-procedure planning that may include CT and labs. Consider anesthesia support, especially if it's a complex filter retrieval. Use 18 or 20 French access sheaths if you're doing jugular femoral access. Get your arterial access if needed. and have immediately available in the room semi-compliant tampon-on balloon, for example, 32 millimeter Coda. I think it's good to have it there just in case. It'll definitely make you feel better if something does rupture, that you'll be in good shape. Here's an example. Here's the Coda, and also have appropriately sized bare metal stents and stent grafts available too. And with that, I will open up for questions. Here's a nice case from, again, my partner Megan Lilly, when she was at Columbia, just using multiple techniques to get these filters out.
Awesome. Hey, thanks, Dr. Resnick. Okay, so we'll just go right into the questions here. So the first one is, do you ever refuse to do a filter removal? And if so, kind of like, what does that look like, or what makes you kind of refuse to do it?
That's a great question. I had a referral from a vascular surgeon, which right then and there, that typically will tell you that it's not going to be an easy case if they're sending it to you. That the patient had it in for about 20 years and then decided that she wanted it out, and had no symptoms, but just decided that, she read a report about the risks of having it in, and decided that she wanted it out. And because she was completely asymptomatic, she was elderly. I just, I went through the risks of removal. She had it in for 20 years with no problems. Not to say she couldn't have any problems down the road, but I mean, man, that's a long time to have it in there. And unless there's a reason to take it out at that point, I felt that it was better served to stay in. I also, I tend not to let, if possible, I tend to like to remove retrievable filters, and I tend not to like to remove permanent filters. Some people, again, have built careers on retrievals, and while I find them kind of fun and of course helpful for the patients and all that, they're great for my trainees. I don't like them to be too crazy, right, and too risky. Yeah. Permanent filters, often if people are going to try to remove them, they'll break the filters intentionally and then take them out piecemeal. But again, whenever you're doing that kind of stuff, the risks do increase.
Makes sense. And so with that one too, kind of going into, so if your initial run shows an embedded apex, do you immediately go to complex techniques, or like the hangman balloon, et cetera, or do you try a standard first?
That's a great question. If I find that it's pretty clear that it's up against the wall, I'll still give it a go, right? I mean, usually at that point we have opened the kit, and this is of course if there's no CT and we don't know ahead of time, and we're just kind of seeing the patient, and I'll give it a go. But I set a time limit for myself and my trainees, because I learned that pretty early on, that if you don't, you'll spend an hour there trying to go after it. I find there's the law of diminishing returns here for sure. If I can't get it out within the first minute or so, I mean, it's probably embedded, and it's probably not going to get out with simple techniques. So then I'll start going towards the more advanced techniques, and I usually go down them the way that I showed. I start trying to do like a sling technique, a loop snare technique, or a variation of it, like I mentioned, and fiber cap displacement, all that, and then I'll just progress down to there, alligator forceps if necessary.
Okay. And with that, so what sheath, brand or size, do you like to use for when you're doing those advanced techniques?
Yeah, absolutely. And I mentioned that too. I like to, for me, for the jugular, the 18 French 40 centimeter Cook sheath is quite perfect. I find, and so I go big. I know when I used to, even in my training, we were taught, go 10, and I used to think 10 French was kind of on the larger size, and I would use usually a 10 French arrow, and which is nice sheath. But and I would go maybe like with 6 inside of that. But as time has gone on, I've realized that it's a vein, and often the jugular vein and certainly the femoral vein, these are large veins. These are very large veins. It's a very small difference to have a 10 French or an 18 French sheath in, and it can make the world of difference for what you're able to do. So I just learned at this point not to mess around. I go straight to an 18 French sheath in the jugular, and if I'm doing groin, if I'm taking off femoral, there's usually a reason why I'm having to go to the femoral. It means it's going to be extremely complex. So if that's the case, I'm going to invert it or do something really fancy. I'll often use that 20 French Medtronic centric sheath, and that's quite useful. Now, if I'm just going to get femoral access to throw up a snare or something like that, maybe like a sandwich technique or some of these other techniques. If it's something just to kind of, then I may not go so big. But I'll tell you, I've just, like I said, over time, I stopped messing around. I just go straight to the large sheets, and I haven't been sorry about that. You just hold pressure a couple minutes longer, and it's a vein. It'll stop bleeding.
Makes sense. What about you, Dr. Amin?
Yeah, I'm same here. I mean, go big to start off. It's going to be, the same thing. If you start mucking around and you're trying to, if it's not, coming out within that first few minutes, then it's going to be embedded. Then just, put the wire down, upsize your sheath, and then try some more complicated stuff here.
Makes sense. So continuing on here, do you ever consider cone beam CT?
Oh,
Right.
Cone beam.
Yeah, and I mean, often I'll have again a pre-procedure CT if I have any suspicion, but yeah, I've done that for sure, and that can be helpful.
Okay. And so what about the last question here is, what would you say to clinicians who suggest that there's no data out there to support even placing a filter, or they're totally against it? How would you rebut that?
In many cases, we don't really even have to, I find, because it's, while I understand that argument, I even alluded to it earlier, it's one of those things where it's now come into kind of standard practice, right? So people say, well, the data is it's hard to get a good study of that. Who's going to want to participate in that study? If it were my family member, I'd want something there to protect them to catch any large clots. So I definitely want to hear Ketan's take on this, but my take on it is that for the indications that he mentioned, those very, there's kind of more solid indications that the patient can't be anticoagulated or has progression of clot despite adequate anticoagulation. In my mind, those are reasonable indications to place a filter.
Yeah, and good luck trying to get that study published. I mean, you're right. Who's going to really, that doesn't seem very ethical, in my opinion, to try to get that study done. But you're right. I mean, sure. I agree with you there, Neil. I mean, I would just refer them to the indications from our societies, depending on what kind of doctor they are. I'm like, hey, this is what our society shows, the Society of Interventional Radiology. Here it's not just interventional radiology, it's the American Heart Association, it's the American College of Chest Physicians, so
absolutely. And I don't know about you, but I found that it's actually quite the opposite. I've had the opposite problem, is that like they always want filters placed.
Exactly. I've never come across where I need to convince a physician to place a filter. It's the opposite. It's trying to talk them out of it because you're like, yeah, that's not really an indication. Yeah.
Yeah, absolutely. In fact, I just had a very similar case this recently where I had to say it was a young patient and had, and I said, I just don't, had a hard time anticoagulating the patient. And I said, they are being anticoagulated, and I think you should first work on anticoagulation and get that straight because it's a young patient and what have you. But yeah, it's usually me trying to kind of bat them off and say, and this is
exactly.
This one maybe not so much.
Yeah, makes sense. And so there's actually a follow-up question to the larger French sizes. So when you use that larger sheath, 18 to 20 French, how do you achieve homeostasis? Is manual compression adequate?
I found it to be so. Yeah, just the whole pressure longer. Some people, have other techniques, for it, but I haven't found the need to do anything other than hold manual pressure.
Yeah. I mean, if you want, there's always, you can throw in like a purse string suture if you feel comfortable doing that. I know in cases where I've done, angiovac procedures need a very large sheath, right? So, but generally, you're right. I don't feel the need to do other than manual compression.
But that's a good point. I'll do that too with the purse string suture. That is helpful.
Well, that is all of the questions that we have. I want to thank you guys again so much for your time and giving these presentations. I found it very informative. I learned a lot tonight. Thank you for everybody who's attended. And with that, we will sign off and look forward to seeing you guys around. Have a great evening, everyone.
Thank you.
Bye.